They all participate. Then we get radical, and we have participatory action research groups. And people get together and they establish a mission. The team does, and this is an example of a mission, to change work such that PCAs are better able, that's patient care assistants, are better able to be healers and experience their work as sacred vocation. And then they produce they define what that means more explicitly. So for this one, to be better healers, they want to better comfort patients and families. We've heard a lot about this today. You know, the work has become so intensive and instrumental that the one thing that people really want to do, they don't get the time to do. And I like to joke that this program is really about how do I recover 5 to 15 minutes of my workday so I can do what I want to do. So they have to improve workload management. Sorry, I was hoping this was not there. And these are the issues that they identified. Reducing time off the floor. So when a patient leaves the hospital, right, it's the tech's responsibility to take them out. And they can't leave that patient until their family picks them up. Well, that can be as much as 45 minutes. And you know, when you're one tech on a floor that has 3 nurses and 25 patients, and you're managing 10 of those patients, and you're off the floor for 45 minutes, that's crazy. Improved communication between the nurses and the techs, that's not new. It's pretty much what everybody does. Improve unit-to-unit communication. Again, you know, people show up on your floor, they don't know about it. Improve the ability to determine when and how to do work. We've heard about that today. Control matters. But also provide development opportunities and clearly defined criteria. People want to grow in organizations. They commit to organizations and they want to grow. And we very quickly depersonalize it and make it that they don't want to. And so these were things that the patient care assistants developed. It's not ours. It's a facilitated participatory process. They develop it. They own it. They make recommendations. These are some of the, so they made this group made 4 recommendations as part of an action plan. And the action plan describes the mission, the model of change. It describes the recommendations and then measures of success. So we actually engage them in a process of, so if this was implemented, what would success look like? And then they make a presentation to management. You can imagine a room with 12 patient care assistants. Most of them have GEDs. Making a presentation to the CEO, to the chief nursing officer, and to all the nurse managers, and to many of their colleagues about what they would recommend to allow people to do their work in a meaningful way. It's a very, very powerful statement, and it's a very, very powerful experience for them. Different organizations do this differently, but this is basically what participatory research is about. Management is always briefed on this ahead of time so that we want them to say yes to some things. This is, again, you know, you wouldn't want somebody to show up and go, no, we're not going to do any of your recommendations. So it's a bit of a managed process, but usually the recommendations are such that they want to implement them. The first time we did this, the group made 28 recommendations. I had this brilliantly designed study with a control group and everything, and the chief nursing officer and all the nurse managers who were on my advisory board said, you're done. We're going to implement these recommendations hospital-wide. Bye. They loved them. One of them was to train people in how to put soap into the soap dispensers. Because if you put it in backwards, it locks up. And, you know, you'd think, okay, they've got to know this, right? But no, they didn't. I mean, you talk to the workers, and actually they have a lot to say. And this is the pretty picture I show. You know, what you expect is workers discover their vocation, workers contribute to creating a meaning-centered workplace, the program gets integrated, and then you get increasing organizational improvements. So let me just tell you one example of this now. We've been working with a large healthcare system in Dallas, and this is from a tertiary care teaching hospital. Frontline caregivers were invited to participate in the years 2004 to 2007. The frontline caregivers were patient techs, assistants, nurse assistants, and unit secretaries. We got about 240 people participating. We had a control group for what I'm calling the business outcomes, which is injuries and retention, doing the same job codes, but they didn't participate, so we knew these people. We had administrative data to look at it. And then we also did questionnaires for mental health and effective commitment to the organization, but we don't have a control group there because it wasn't really designed as a formal research study at the beginning. Some important things to say about organizational change. Again, everybody knows this. You need to have leadership commitment. And I'm not saying management commitment here. You need leadership commitment. Leadership can come from a lot of different perspectives. But the employees were paid to come in during off time to attend sessions. I mean, one of the challenges of organizational change in healthcare settings is you can't pull people off the floor in the middle of their shift. It doesn't work. It just won't work. It creates real nightmares. We've done that in 2 facilities with the assistants. And when assistants get pulled off floors, what it does is the assistants that aren't pulled off the floors get really angry at them because they have to cover. So you have to be cognizant of that. This group provided gifts during the ceremonies. Foods and certificates were presented during some of the sessions just to make it more fun. But they also made sweaters because the nurses in this hospital were magnet status, and they all wore around this really pretty purple sweaters that had, you know, the name of the hospital and magnet status on it, so all the techs wanted a sweater. So at the final graduation, they gave everybody sweaters. It's, you know, and then you see everybody walking around the hospital with these on. They host a party every year. It's a wonderful event that, and the hospital basically acknowledges all these people. It's run by the workers. They've established a committee for this. They run it. So here are the 3 outcomes I'm going to talk to you about today. Mental health, which is the SF-36 MHI-5, varies from 0 to 100. It's really a measure of affective commitment, maybe depression. 65 on it is considered clinically depressed. Injury rates, OSHA reported injuries and actual hours worked in a 2-week pay period. We spent a lot of time trying to get real data as opposed to just, you know, using data that was there and available. Retention time, which is a big issue. So I know we're not supposed to show slides of data, but here's just one slide that basically shows you that this population of patient care assistants is predominantly African American, predominantly women, wide age of range, and what you often see in this occupational group in the US, a bimodal distribution of job tenure, a lot at the early years and then at the end. So this is the change in mental health. I will tell you is that we had a significant change in mental health pre to post. It was about a 5-point change. Turned out that on unit, lots of people participating in the program, the change was greater than on units where they had fewer. Again, you shouldn't be surprised. If you're really trying to change the environment, it matters to have more people participating in something. Here's injury rates. I show this to just make a point for those of you that know me that I always like to make, which is be careful of studies that don't show you control groups, because you might conclude from this, just looking at the, I don't know if you can see this, at the in group, that that went up and that it wasn't effective. But as you can see, it went up so much more significantly in the control group that the relative difference is huge. And I can tell you the story for that if you're interested. But this happens a lot in different organizational settings because they don't stop doing what they do because you're doing a research project. So just to kind of give you an overall sense of the effectiveness, what happened, we think the project has led to preventing 23 injuries per 100 full-time employees based on the data we have, and it retained an additional 27 employees compared to the overall population. So if you try to use back of the envelopes, that's a retention estimate. If you try to use back of the envelope calculations, the injury savings are about 55,000. The turnover savings are about 750,000. So the total cost savings are about 800,000 for a program that cost about 60,000. This is a very low-tech program. So, participants in a high engagement work intervention had improved mental health, reduced injury rates, and increased time to termination. They also had improved effective commitment to the organization. And there was a consistency of effect. It was an improvement across multiple outcomes. So as you would expect, if you improve mental health, it's one of those wonderful signaling measures in an organization that tells you some other things are going on that are important as well. It just captures a lot of a person's experiences, and it seems to correlate with reduced injury rates, improved retention, improved effective commitment. And I think importantly, the message that I would like to say is we often focus on structure, that, it's all about the work. It's all about, changing the staffing ratios. And I'm not against changing staffing ratios, patient to staff ratios. I think we should. I'm a big fan of the Scandinavian model. But we can also focus on job content. And I think particularly over the last 20 years, we've really moved away from a focus of interventions that attend to content of work and have gone to the structure of work. And I think the content of work, and I think all the projects that have been presented have been balanced in talking about both structure and content. And I think it's important to pay attention to content. And I think, these results translate into hospital cost savings. I think anyone doesn't believe this. We've shown this. The take-home message for us was the healthcare system, which has 13 facilities in the greater Dallas-Fort Worth area, has now taken this to all of its healthcare facilities, and we're now shamelessly being used by several quality improvement groups in the United States, and they've incorporated a lot of what we do into their quality improvement, so, it's flattery for us, but, we do stuff that kind of makes a little difference in people's lives. And I'd just like to now extend thanks to the employees and management of the participating hospital. They were wonderful and great and continue to be. I was trying to show a video, but I was afraid if I showed a video, it would blow out the system. So, there you go.